okay, that's that. Let's go to the troublemaker who took up the whole middle section of the board. This one I had to do tricks. I don't do all tricks. I think students who look at all mnemonics for everything are crazy, because after a while your mnemonics run together. So we don't do a lot of mnemonics in my class. We do just enough. In this case, I like it. I do like this mnemonic, and I have one other one on the other board. This mnemonic, you got to be careful, teaches you the causes. It doesn't teach you signs and symptoms. It's teaching you the causes of why a patient has a high K, and the mnemonic is matches. And thankfully, almost everything in it makes sense. Some things don't, and I'll teach you it. But I think you can agree that with a patient that has a high K, medications might be the reason. What kind of medications? Oh, any kind of medications that kill the kidneys. Because if you kill the kidneys, I can't pee. And if I can't pee, I can't get rid of my K. Because I keep telling you the only way to get rid of potassium is to pee it out. So I put NSAIDs because most nurses screw that one up. You do not give NSAIDs to renal failure. You don't. I could have put aminoglycosides because unless your patient is on dialysis, in which case I would dialyze the vancomycin off of her. Unless they're on dialysis, we're not going to get nobody no vanco when they have kidney function problems, kidney disease. So anything that kills the kidneys, medications-wise, anything that kills the kidneys is going to cause hyperpotassium, hyperkalemia. Okay, acidosis. Let's try that again. Acidotic patients are usually patients that are either in shock, because all shock is acidosis. All shock is acidosis. And we have to remember the other rule. All shock has a low blood pressure. If you have a low blood pressure, you're not really perfusing your kidneys, because blood pressure stood for BP, blood perfusing kidneys. Acidotic patients don't have a blood pressure. They are usually in shock. When you have acidosis, you're probably not doing well with your kidneys. That may be one of the reasons why you have acidosis, because uric acid builds up and you have acidosis. You can't pee, you're not going to get rid of the K. You're just not. Okay? ACE inhibitors, oh God, if we talked about those, we'll go and face in here. ACE inhibitors, they don't cause the K to go high. They just cause the sodium in water to go low, and they're opposite. So if you're on an ACE inhibitor, it's going to get rid of water, it's going to get rid of some salt, and it does that through the aldosterone channel and the angiotensin channel, and we'll talk about that later in case you're confused. But for now, we don't have time for that. So you had to remember how ACE inhibitors work. They worked on renin, angiotensin, aldosterone system. And when they worked on angiotensin, they caused vasoconstriction. When they worked on the aldosterone, they caused you to get rid of water and salt. When you get rid of water and salt, you cause K to go up. That's the only reason ACE inhibitors are in there. Trauma. This type of trauma is crushed bone, or any kind of trauma where the cells themselves are lysed or destroyed. K is always inside of the cell. It's always an intracellular electrolyte, always. So if you, watch me, if you crush the cell as you do in trauma, the K comes out and it becomes high. Your burn patient and your crushed bone injury patient, that's who this is. Oh, blood transfusions. If I give you blood cells and potassium is in every cell, I gave you extra potassium. You have to monitor the blood transfusion patient for a hyperkalemia. Too much KCl, common damn sense there, I ain't gonna teach that all day. Cellular lysis, I just showed you. Destruction of the cell opens it up, lets K come out, and that's what lysis is called. So what do we mean by that? Oh Lord, watch this. This is a hookup, holy, holy hookup. Every single time you see lysis in a word, the K is high. Every time you see lysis in a word, the K is high, and here's another one for you. The calcium will be low. Every time you see lysis in a word, the K will be high, the calcium will be low, and the phosphorus will be high. Because K is the one you learn about in school as being in every cell, but you probably don't remember necessarily, because I didn't, that phosphorus is also in the cell with the potassium. So if you lyse the cell, out comes K, out comes phosphorus. Every lysis condition, and they're always on NCLEX, always. Every one of these conditions has a high K, a high phosphorus, and a low calcium. So with cancer, don't be confused. You could have, with cancer, a high calcium or a low calcium if you get tumor lysis syndrome. That is the one thing about cancer, and I tell you the way to remember that is CA starts the word cancer. Remember, calcium could be high or low. CA begins the word cancer, and with cancer patients, the calcium could be high because of the cancer itself, or it could be low because of chemotherapy causing tumor lysis syndrome. What did chemo do? It destroyed the cell. And it let all these things come out, and it let the ones in the extracellular fluid leave out. Again, with cancer, calcium can be high or low. The way it's low is the chemo itself. The chemo destroys the cell, potassium gets high, phosphorus gets high, calcium goes low. Any lysis patient. Any lysis patient. Okay? Now, okay, so we're high, right? We're high, so let's stick with high stuff. The only person that didn't stick with high stuff was the two on the outsides of my board. But this one is a little bit of high stuff. Peaked T-wave. What is a peak? This. Peak points up. High potassium, peaked T-wave. That's how I remembered it. And that is on a whole lot of tests, that peak T-wave. That's a whole lot of people take a test to get that. YQRS. Whew, great. That's ugly. If you know anything about a QRS, it's supposed to do this. It's like, ooh, nope, not good. Okay, so wide. Horrible. VFib. Oh, hell no. That's the worst one on the board. What does VFib mean? You ain't got no pulse. You don't have any responsiveness. You're dead for the sake of dead. And I can bring you back with the DFib. All VFib gets a DFib. So that's crazy. You already know that's crazy. Brisk DTRs. Brisk DTRs. Told you the one in the middle is everything's kind of high. Brisk DTRs. High K, stay with your girl. You're moving too much in your GI system. Diarrhea. Yet, again, I told you that if you give this damn patient too much K, you can kill their kidneys. And if your kidneys are already dead, you're going to have a high K. It goes back and forth. You give the K, you kill the kidneys. If your kidneys were dead already, you're going to have a high K. It just goes back and forth. So oliguria just makes sense. Now the solution is tricky on different tests because you got to read it, y'all, for real. When they give you these questions, you got to say, okay, wait a minute. Is it an outrageously high potassium or is it slightly elevated? If it's slightly elevated, then I'm going to always, no matter what kind of elevation it is, I'm going to always hydrate first. Look what I wrote. I wrote that first. And then I'm going to chase it with some K-Exolate, which is like usually an enema. So it's just like mildly increased. I'm going to hydrate the patient first. I hydrate the patient first no matter what the deal is. And then I'm going to chase it with K-Exolate. This is where things may be different depending on what's going on. Because here's our issue with K-Exolate. It's too slow. It's not fast enough. It's a freaking enema. I got a sister-in-law who had to take that crap. And I said, honey, you might want to call in off of work tomorrow. Why? Oh, because you're going to have diarrhea the whole day. Really? I thought, well, why not get it over today? That's not how K-Exolate works. It's slow. You're going to be off school tomorrow. Trust me. You might want to call in and tell somebody else got to do them third graders. And so she said, oh my God. They gave it to her the day before. But how does it work? It doesn't work very fast. So here we go. If the K is really high, like outrageously deadly high, what's deadly high? 6.2, 6.3, all that old craziness. We need dialysis. If the K is outrageously high, we need dialysis. If it's not so bad that we're losing consciousness, and maybe it's like 5.9, 6.0, we could do an insulin cocktail. But it don't matter which one of these I did, I always hydrate it first. Now let's do an insulin cocktail for people who you know damn well they just need to get this K off of them now. We're going to push, IV push 25 grams of D50W. This is every ER in the world. IV push 25 grams of D50W, 10 units of insulin, IV, of course, regular, right guys? Because the only one we can give IV is regular. Lasix, and still K-Exolate. Still gonna give a little bit of that. That's called an insulin cocktail. You had to know that insulin lowers K. You absolutely had to know that. We rarely give this guy bicarb, even though all of them are in acidosis, because acidosis and a high K go together. We rarely give bicarb unless they're in full-blown acidosis and we're not correcting it fast enough, then we'll give the bicarb. But we don't usually give it, but I wrote it just in case. You had to know the acidosis connection, because bicarb and acidosis is opposite. Again, I rewrote it. Dialysis if the K is ridiculously deadly. Then what are you messing around for? Just get it off of them. Do dialysis.